Hi everyone, today I'm going to do a case presentation on a mild mixed moderate hearing loss in a 2-year-old. Origin of the case. This case was adapted from the Pediatric Audiology Casebook, 2nd edition. The chapter, Management of Mild Moderate Mixed Loss in a 2-year-old Boy by Josephine Marriage, presents the case of a young child referred to as A, who is diagnosed with a mild to moderate mixed hearing loss identified during early childhood. This case outlines the child's developmental background, the diagnostic findings that confirm both conductive and sensory neural components of the loss, and the clinical decision-making process used by the interprofessional team. Case history. Our client, referred to as A, is 2 years, 1 month old. Reason for referral: parents requested a hearing assessment due to reduced speech clarity and difficulty understanding his speech. The newborn hearing screening was not completed as the parent declined screening at birth. A's speech and language characteristics. He has an expressive vocabulary of approximately 100 words, and he primarily uses single-word utterances. He has poor speech intelligibility characterized by limited consonant production, but does have a stable vowel production. His medical history refers to frequently experiencing colds and nasal congestions. He has a family history of his father who presents with an untreated mild to moderate hearing loss. The initial audiological testing and outcomes. The tympanometry revealed flat tracings bilaterally, a type B TIMP. Otoscopy revealed red vascular tympanic membranes with visual fusion in both ears. At 2.1 years old, Adam successfully completed a condition play audiogram for each ear using air and bone conduction, indicating strong cognition skills and sustained interactive attention. His hearing diagnosis was a bilateral, moderate, mixed, conductive, and sensory neural hearing loss. A's speech intelligibility index score at 65 decibels is below 40%, meaning he perceives less than half of the speech information at typical conversation level. A is reported to have difficulty with perceiving high-frequency sounds. Audiological intervention outcomes. It was recommended that A has air conduction hearing aids behind the ear hearing aids with ear molds and an FM system. An FM system was recommended to enhance the signal-to-noise ratio and support consistent access to spoken language. It was also recommended that there was a medical evaluation and potential treatment to address the conductive portion of the hearing loss, for example, the effusion or middle ear issue. Monitor his hearing and middle ear function, speech and language development over a defined period before determining the next steps. A was fitted with a BTE hearing aids using soft shell ear molds. He was also seen by an otolaryngology surgeon for removal of his adenoids and insertion of PE tubes, and had the surgery to remove them 2 months later. A's hearing responses were reported to have improved, but his speech clarity continued to be poor. He stopped using the BTE hearing aids once the conductive component was improved. A second audiological evaluation was given at 2.5 years old. A follow-up audiogram revealed a mild bilateral sensory neural hearing loss. Although A continues to show strong engagement and vocabulary, his speech clarity remains reduced. With unaided SII scores of 63% in the right and 67% in the left, he is likely to benefit from appropriately fitted amplification to support clearer speech during this key stage of language development. Poor speech perception, particularly for soft speech, limits his access to the acoustic cues needed for incidental learning, causing him to miss many everyday language opportunities. Second audiological outcome, Adam was fitted with the bilateral BTE hearing aids. He did not wear full shell ear modes, as this restricted his hearing of environmental sounds, and was changed to size 0 open slim tube fittings, from which he has worn from the age of 2.7 years. His speech clarity is improving with speech therapy. SLP intervention and SLP scope of practice. So for A, we want to support speech, sound development, and intelligibility. We want to use auditory, verbal, or listening spoken language strategies to help A discriminate between similar consonant sounds he might be missing. We want to use visual and tactile cues, such as airflow visuals for fricatives to support motor planning and clarity, and provide high-frequency sound activities in structured and naturalistic play. We want to build auditory skills with amplification by practicing auditory discrimination tasks, such as same or different, And we want to work on A's auditory memory by repeating 2 to 3 word phrases. We also want to develop listening and noise skills during play with classroom-like background noise. We want to monitor the impact of hearing access on speech and language. Track whether A responds reliably to soft versus average speech during sessions, and share observations with audiology to support decisions about FM system use. We want to collaborate with the audiologist and share speech sound production patterns, such as consistent omission of high-frequency sounds that may signal insufficient access, and we want to coordinate timing for hearing aid checks and FM system trials. We want to partner with the family and show the family how to model clear speech with good visual access, encourage full-time hearing aid use, and using routines such as mealtime, bath time, reading to build listening and vocabulary skills. Lastly, we want to strengthen expressive and perceptive language skills. A has reduced access to soft, high-frequency sounds, so the SLP can model and practice early morphemes and build vocabulary through multimodal play. Here are my references, and thank you for listening.